So the central veins, they act like a highway. So if you are putting lines in big veins, there's more risk for the patient to become contaminated than if you're using smaller veins. They're not like, central. They are central, but not, they have a separation. Hello, welcome to the Nurse Multiverse podcast. My name is Gene. Today we're going to be covering vascular complications and considerations. There's a lot of not a lot of material to cover, but it's fairly complex. So we're going to be doing our best to kind of go slow and go always over definitions first. That way everybody understands what we're talking about. All right. So definitions, important definitions. CLABSI. That stands for central line associated bloodstream infection. DVT. That stands for deep vein thrombosis or clot. So a clot on a deep vein. At some point, we're going to study specifically the veins in the body, but for now, just know that there's shallow veins and deep veins, and a DVT is a clot in a deep vein. Nosocomial. What nosocomial means is a disease originating in a hospital. So basically, you go to the hospital and you get different kinds of complications that arise in hospital. CVC. CVC stands for Central Venous Catheter. All right. We're going to be looking at studies today, um, 3 or 4 different studies in order to support our arguments and our explanations. And an important word to remember is prevalence, which is a measure of the total number of people in a specific group who have or had a certain disease, condition, or risk factor. Examples include smoking, obesity, diabetes, and other chronic ailments. An important thing to an important thing to talk about is the cost and the complications arising from CLABSIs and DVTs. So if you go to the hospital, you get an operation, they put a central venous catheter in you, and that catheter becomes infected. It gives you a bloodstream infection or a CLABSI. The cost for that to treat that infection is between 48 to 68 grand, and it can go all the way up to 90 grand or more depending on how many you have. So one CLABSI costs 48 to 68 to fix. One. Let's say you go to the hospital and your hospital stay gets complicated by 2 or 3 of these infections, the cost starts rising up. And this most nosocomial infections or infections that arise in the hospital are not reimbursed by the state. So the hospital is not going to get paid for this um, complication. All right. For the DVT, the treatment cost between 17 grand and 22 grand. All right. And what CLABSIs do is they make you stay in the hospital longer. And there's an increase by 30 days per CLABSI. So let's say that you go in, you get an infection, they treat it, put the money into that, you stay extra 30 days, which increases your risk of further complications. LOS stands for length of stay. All right. Any questions? Is that kind of understood? Yeah. Okay. So we're gonna move on to something called the vascular exhaustion model. So this is basically applied to heart failure, but you can apply it to any disease specifically, and the parameters will change a little bit, but not much. Um, so let's say you show up at the hospital with decompensated heart failure. All right, either by usually a heart attack, right? You get a heart attack, and your heart just decompensates and is unable to keep your organs supplied with oxygenated blood or red blood. You get admitted to the ICU, which is the intensive care unit. Once you're there, you're exposed to multiple vesicants. Vesicants are agents that cause blistering. So they cause blistering within the lumen of the vein and therefore destroy the vein. There's two main categories of vesicants. One is the vasoactive drips. Vasoactive drips affect blood pressure, heart rate, etc. And then antibiotics, who destroy infection causing organisms. All right. So we had the compensated heart failure. We went to the ICU. We received medications either via peripheral access or central access, and these medications affect your vasculature. You start getting better, and you transition to IMU, which is the intermediate medical unit. Patients in that unit should not have central access because the nurses are usually not trained for that. The patient load is usually 4-1. In the ICU, the patient load is 1-1 or 2-1. The more patients you're taking care of, the more organisms you are carrying from bed to bed, even if you follow strict guidelines and wash your hands and all that. So the risk of infection or collapsing in this case increases by the amount of patients you're taking care of. If you work in a hospital with a high ratio of of patient to nurse, it's kind of similar to when a teacher is having a class of 60 students versus a teacher is having a class of 30 students. All right. It's a cumulative effect. All right. So let's say you're transitioning to IMU, but we cannot obtain peripheral access on you. This is when the ultrasound access becomes very important. Um, so the patient goes to the IMU with a short term central vascular access. That's when they get eclampsia. They could get eclampsia in the ICU, but usually it's going to be on transition where they get it. All right. Um, so what happens is when we cannot start peripheral access on you, we do a conversion of the short-term access to long-term access. That's the PIC line. PIC line stands for peripherally inserted central catheter. It's a long-term device, but it's not necessary all the time. But what happens is we cannot start peripheral access on you. So we go ahead and we start this long-term line in people that sometimes don't need it. And by doing that, we're putting you at risk of further collapses or DVTs. There's a high incidence of DVTs related to PIC line access. Excuse me. So as a result of all these treatment, oftentimes the patient develops DVT or collapses at some point within this model. So it's like a circle. It can repeat itself. Every time it repeats, it depletes a certain amount of your vascular health. If throughout your life you got to go to the hospital, let's say you're 50 and you got to go to the hospital 3 times every other month or every 3 months, this is important because it's a cumulative effect on your vascular system. So this process can repeat indefinitely during the hospital stay and therefore depleting vascular health, increasing costs, and lengthening the time of stay, which puts you at risk for more complications. Any questions, Jay? What do you think about that? I'm sorry, guys. It's not COVID, I promise. It's just some cough. All right, so now we're going to go deeper into the whole collapsy phenomena. All right, there's a lot of nosocomial problems, which we'll cover at some point in its totality. But right now, we're just focusing on specifically central line associated bloodstream infections. All right, so we already learned what prevalence was. Prevalence was a measure of the total number of people in a specific group who have or had a certain disease, condition, or risk factor. Incidence. Incidence is the measure of the probability of occurrence of a given medical condition in a population within a specified period of time. In this case, we are looking at collapses. And the data was obtained from a research study done in Hanover, Germany. Um, so the study name, if you guys want to look it up, is Incidence, Risk Factors, and Healthcare Costs of Central Line Nosocomial Bloodstream Infections in Hematologic and Oncologic Patients. It's a 3-year study. And just to delve in a little bit of what hematologic and oncologic means. Hematologic, it's any disease that affects the physiology of the blood. Oncologic refers to the treatment of tumors, cancer. The location for this study was the Institute for Medical Microbiology and Hospital Epidemiology in Hanover Medical School in Hanover, Germany. Epidemiology, which is a handful, it's a branch of medicine which deals with the incidence, distribution, and possible control of diseases and other factors relating to health. Other studies that we used in order to get the data that I gave you guys about the cost and the length of stay include a study called Estimating the Additional Hospital Inpatient Cost and Mortality Associated with Selected Hospital Acquired Conditions. This study was a screen of other studies, up to 4,000 articles in meta analysis. So, meta analysis is the statistical analysis that combines the results of multiple scientific studies. These studies are very helpful because what they're doing is they're gathering all the data and they are giving you the interpretation of such data. So a lot of times when you look at different studies, they're done in other countries, they're done differently. So in order to get the best possible information, you want to go to the broadest, basically, like this is tailor made to be able to make an argument or to be able to do a treatment plan, which we're going to cover in a minute. And another study that's very interesting is the impact of nosocomial infections on mortality, length of stay, and hospital costs in older adults. This was done by the National Institute of Health, and it's a study that was done from 1994 to 2002. Good. Okay, moving right along. The protocols. Basically, one of my endeavors in my career involved lowering this collapse rates at a hospital in Houston, and we had a task force. We noticed that we were having a lot of infections um, over time at the hospital. All right, the study done in Hanover, for example, what they discovered was that the incidence of collapses were 10.6. So basically, most patients had an average of 10.6 collapses per thousand central vascular catheter days. All right. So this is it's a formula that I'm not gonna explain right now because it pollutes things. Just understand that during a period of 3 years, patients had an average of 10.6 infections. Multiply that by 68 or 68,000 or multiply that by 48,000 and the costs start rising. Um, so we used something called the MAGIC study, which was released in 2015. And MAGIC stands for the Michigan Appropriateness Guide for Intravenous Catheters. Right? It was published in the Annals of Internal Medicine. You can find it on Google for free. All of these studies that I am quoting, you can find them on Google for free. So if you want to understand a little bit deeper, all the information is there for anybody to understand. All right. This is something that, especially if you have anybody with chronic disease, it's something important to look at when you're choosing a hospital. These scores are public. So when you're choosing a hospital for your parent, it's important to look at these incidences because this tells you if the hospital is safe for your parent or not. A lot of people go in the hospital to treat one thing and they come out with three. So the team for this task force included the critical care physician, who's the doctor that works, is usually a pulmonologist, and they work in the ICU all day treating patients. They don't have offices, they work in the hospital. alongside the nurses. Um, Another team member was the quality improvement nurse. So the quality improvement includes CLAPSIs, but there's other parameters as well, like pressured ulcers acquired in the hospital, um, urinary catheter infection, falls. All of those different parameters fall within the quality improvement nurse. What they're basically doing is just checking that everybody's doing the right job, everybody's washing their hands, the patients are well cared for, the call bells are getting answered in time. So it's a very stressful position. I did it for a couple of years and I did not enjoy it. Um, because you got to be the bad guy basically. You're like having to tell people to do things, and that's one of those things that to me it's a little bit unnerving because I feel like people should know what they have to do and follow without having to be told. And last is the vascular specialist or IV therapist, and this can be a physician or a nurse, but it's just somebody that's actually planning the vascular access on the patient in a smart and premeditated way in order to prevent these complications from arising. So the actions that we took were focused on prevention strategies. All right. The first prevention strategy is, where is this CVC or central venous catheter inserted? And we have three options. They go from best to worst. All right. The best practice is to start these access in the subclavian vein. Why? Because the catheter travels through the skin, that creates a barrier for infection. So basically, the closer you are to a big vessel, the more risk it is for that to become infected because the bacteria can access. So the central veins, they act like a highway. So if you are putting lines in big veins, there's more risk for the patient to become contaminated than if you're using smaller veins. They're not like, central. They are central, but not, they have a separation from the central area. Acceptable access will be the jugular access, which is the most commonly used, right here or right here. Subclavian, jugular. And the worst access, which is mostly done on emergencies, but almost all hospitals are moving away from this because there's a high incidence of infection here, which is in the femoral vein, which is in your groins. All right. This is usually done when there's no recourse or when you have a patient that's vascularly depleted because they went through the vascular exhaustion model that I talked about earlier. So basically, these patients have no access on the arms, no access on the subclavians, and no access on the jugulars. It could be done by stenosis or it could be done because they have a clot there. So that's the first thing that we focused on: correct placement in the correct place. And the second thing that we started monitoring was the time limits for indwell. Indwell just means inside of your body. So for subclavian access, the indwell time was 7 to 10 days. In the jugular access, 7 days. And in the femoral groin access, 48 hours or less if clinically stable. If the patient is not stable enough for you to change the line, or there's a mechanical problem where you cannot put a line on a better space, then you're stuck with that. But it's good to understand that that can become a problem very easily. And just a small variable, lines placed in outside hospitals were to remove ASAP, less than 48 hours optimally if clinically stable. Why? Because a lot of times the medical continuity gets kind of lost on admission. And what happens then is you don't know how long this patient has had the line or if they did a correct procedure because you're not in control of that. So whenever a patient will come into us transferred from another hospital and they had a central line, we would immediately start the ball rolling, deciding where we want to remove this line. But the best outcome would be if we did this within 48 hours. And that's it. That concludes kind of like what we're talking about. Do you have any questions or anything to add, or like, conversation, anything that you found interesting? Yeah. Okay, guys. So that's about it for today. Again, if there's things that you didn't understand or you're really interested in this, there is free articles for everybody to read. um I'm not going to give the website here because I don't have it, but if you just google free medical journals, it'll bring you to a page where there's a list of sites that give you these studies free of charge, the same studies that other sites are trying to charge you for. So it's very accessible. And like I said, these studies are very interesting. They're usually like maybe 10 or 12 pages long. And it's good to be educated, especially if you are a primary caregiver, meaning you take care of your parents, of your daughter, or your son, or anybody that is in a primary care position should be aware of this. You don't need to be an expert, but it's good to be aware of it. That way you can choose the right facility for your significant other, your loved one. All right, guys. So that takes us to the end of this podcast. And thank you. We'll see you next time.